Come on, guys. Come on, dog. Go ahead. I live in Chillicothe, Ohio, and I was raised here in Chillicothe. It's a small community of about 25 or 30,000. At one time, I thought I was going to move to Columbus and start my own practice, but I realized that the small life was better for myself and my family.
We've lived here since the 70s. We came right out of college, and we were just going to come for a couple of years and then move on to Columbus, but we decided to stay, and John went into practice with his father.
I had to retire 8 years ago. Prior to that, I was an optometrist in my own practice. We had a group practice, which I enjoyed very, very much. Right now, I'm just enjoying living. About 30 years ago, I quit smoking, and I knew when I quit smoking, I'd put on a lot of weight unless I'd exercised. And I took up the routine of jogging, and every morning before I went to work, I would jog. And it got to the point that if I didn't jog in the morning, I felt guilty. I even got to the point where I started entering some competition with my daughter, and we did a half marathon. And that was fun. At one morning I was jogging, I noticed I had a droplet of blood in my sputum. I called my family practitioner, and he said it's probably just exercise bronchitis, but to give him a call back in a couple weeks if it's still present. My name is John. I was diagnosed with non-small cell lung cancer. I called him back on a Thursday, and Friday morning I received a call with a diagnosis. I had metastasis into the spine, the left hip, and the adrenal gland. That's the problem with lung cancer from what I understand talking to other patients. Many of them aren't caught until stage 4 when the symptoms are drastic, and mine weren't even drastic. What was unusual about, at least I thought from my point of view, I didn't have any loss of energy or decrease in breath. I was essentially asymptomatic. When I received the diagnosis, it's at 9 a.m. at the office and continued to see patients. That evening I came home and told my wife, and we both cried a little bit. It's essentially a terminal diagnosis, and I guess I pretty much took it in stride. We spent the next week going to my accountant, the lawyers, the morgue, and the undertaker, setting arrangements for their funeral. That's what we did for the full week. So we pretty much, at least in my mind, pretty much accepted what was going to happen. And I just wanted to do it with integrity. I just took it in stride. It was something that I was going to have to adjust to. I told my wife that evening that it was going to be harder on her than it was me. And it really was. I don't know how she did it.
When we learned, I had to let the kids know. John wasn't able to do it.
She had to keep a level head.
I called them and told them, and, we were all just kind of numb. We didn't, everybody was wondering what that meant.
I was stage 4 lung cancer.
No lung cancer is good news when you get that diagnosis. When I started, most patients didn't get any treatment. They got morphine, maybe a little palliative radiation. It wasn't clear that chemotherapy worked at all.
My grandmother had gone through lung cancer, and I saw her shrivel up and die. Some people get mad about the diagnosis. Some people get sad. And I just took it in stride. It was something that I was going to have to adjust to.
That day, we just, went to the funeral director. We went, did all of these things. And Then we went somewhere and had a drink. But we were just deciding that we were going to accept it and move on and, hope for the best. And I guess maybe at that time, I didn't really know what that meant. I just always thought that there was always something better that was going to happen. I had a good friend that had gone through cancer, and she called me occasionally and we'd talk. So we had some, I had somebody to talk to about it.
Lung cancer is very common. It's not the most common cancer, but it is the most deadly cancer. There are many more men that die of lung cancer than any other cancer.
Lung cancer is one of the most interesting cancers to study, in my opinion. From that standpoint, it's such an important problem, an issue to work on. Also, the science is really interesting. Lung cancer is highly linked, as many people know, to a smoking history, and smoking is the #1 risk factor for lung cancer. But it's not the only risk factor. And there's many people who are now getting lung cancer who have no smoking history at all.
Non-smokers are about 15 or 20% of all lung cancers. They've never smoked. They may have secondhand smoke exposure or some other environmental cause, and they still get lung cancer.
People have to understand, yes, smoking, that's one of the major causes of lung cancer. But if you have lungs, you can get lung cancer. I started out here with the initial diagnosis of lung cancer, and they immediately referred me up to Columbus for evaluation and treatment. And that next month was probably the most frustrating time, both for myself and my wife. The first doctor we went into, they received my x-rays, and first question I said, how long do I have to live? And he said, wait just a minute, let's back up. He said, this is what we're going to do. We're going to put you through a lot of tests, see exactly what's going on, see if and how much the cancer is spread and what kind of cancer it is. Then we'll sit down and discuss the treatment protocol. I must have gone through all sorts of tests and went through CT scans, PET scans, x-rays, breathing analysis, biopsies.
That's the first step, is documenting that you're dealing with lung cancer. Often virtually always it has to be a biopsy of some sort. We still need to actually look to make sure that what we're looking at, that nodule in the lung, is not an infection or something else. It's cancer. You need to know where it is, that's staging, and then you need to do the molecular analysis of the cancer. But those features are often called biomarkers. So they're really equivalent. When people talk about biomarkers, they're looking for these driver gene abnormalities and then the PD-L1 expression. There are many subtypes of lung cancer, but in the past, these were classified by the way they looked under a microscope. And so there were ones with small cells, and there were ones that didn't have small cells, and that was the main classification of lung cancer, small cell and non-small cell. And then also under the microscope, you can divide non-small cell into what's called an adenocarcinoma or squamous carcinomas. He was started on a randomized trial that was comparing the immunotherapy to the chemotherapy. And he was randomized to chemotherapy.
Let me put it this way. I was given the death diagnosis of lung cancer, stage 4, and putting me on a trial really didn't excite me. I didn't know what the end result was going to be, so I signed up for it. And when you sign up, it's random. You're put into one of 2 tracks. One was the chemotherapy alone, the other was the new trial drug, immunotherapy, which we didn't know at that point in time. And I was put in the chemotherapy and was started off on chemotherapy. I'd go in and see patients in the morning, come home at lunch, take a nap, go back and see patients in the afternoon, and come home and go to bed. So it had to be very frustrating for my wife because all she could do was just watch what was going on.
Well, it just kind of, those days kind of ran together. I mean, he would sleep in the chair down here because it wasn't comfortable to sleep in bed. And so he was there most of the time. So I just went on about doing what I was doing and let him sleep. And I guess we just kind of fell into a pattern and I got used to that.
I was still in the chemotherapy and they said, we're going to stop the chemotherapy. Your cancer is actually getting worse. And that's when I was given the option of swinging into the second phase of the study.
The study fortunately allowed him to switch over to the immunotherapy. PD-L1 is usually most important in the non-driver mutant subset of lung cancers. It stands for programmed death ligand. It turns out, now we understand that this is a major mechanism that cancers use to avoid immune surveillance, like a force field in Star Trek, where this normal gene, that's a normal regulatory gene that's normally used by immune cells to turn off the immune response when they're done. So if the PD-L1 is negative, which means that if you take a slide with the patient's cancer on it and you look for the expression of PD-L1 on the surface of the cancer, you don't see it. That's PD-L1 negative. It turns out those people have less of a response to the PD pathway inhibitors, but in a combination with chemotherapy, these inhibitors do seem to work somewhat, but just not as well. So we have to use different approaches than PD-1 therapy alone.
High levels of PD-L1 indicate that your cancer might be more likely to respond to immunotherapy. If that percentage is high, your doctor is more likely to put an immunotherapy into your treatment plan, and most likely the cancer is more likely to respond. So we have absolutely seen people with high PD-L1s who go on an immunotherapy.
When we found out that he had PD-L positive, we were excited about that and didn't exactly know what that meant. He was glad to get off of chemotherapy.
We started thinking, hey, this might work, because that was when we got our first elaborate CT scan that showed that the tumors were actually regressing. And that's when we started to get excited about it. My wife was always a believer, but I don't think at any point in time that I actually thought, hey, I'm going to survive all this. We started celebrating the time we were given, and we started enjoying life. And I think at that point in time is when I started enjoying day by day versus worrying what's going to happen down the road. And I go back to just enjoying what was going on at the present moment.
He was a little weak at first, but he was starting to feel better. And he could, go out on the beach and, be in the sun.
Again, I usually emphasize the importance of science-based testing for markers, making sure that you have the best treatment matched for your cancer, and the message of hope and looking for clinical trials that give you access to the next generation of treatment. And it's very gratifying to see that now we have, John, that they're getting engaged in the awareness aspects of lung cancer. Lung cancer used to be the invisible disease. People got it and they died, and you never heard from them. There were no advocacy organizations. But more and more now, people are living with lung cancer and forming these organizations and talking to news outlets and helping attract people, researchers into the field to make the progress and attract funding.
We often find that people don't want to admit to others that they have lung cancer because of the lung cancer stigma?
I was, misdiagnosed like almost everybody in the room here for a very long time. And when I finally found a care team, I realized how lucky I was and how unlucky so many other people were that were not getting the kind of care that I received. So we decided that we just needed to start a foundation and make sure everybody got the care that they so deserved.
No one did anything to deserve this. We want everyone to be comfortable with being able to say that they have lung cancer in the same way that they would potentially tell friends or colleagues that they have breast cancer, prostate cancer, and other types of cancers. Lung cancer shouldn't have that type of stigma associated with it. And there's a lot of resources and a lot of hope and a lot of new treatments. And we are really proud to say that we support all patients and caregivers with lung cancer and really want everyone to feel comfortable with talking about their diagnosis and making sure that they get all of those resources and all the help that they deserve.
I'm a definite direct benefit of lung cancer research and the drugs that it developed.
Well, it's very exciting. And with the targeted therapies too, we've been talking about immunotherapy, but the development of these targeted therapies, literally the cancer cells would blow up. When you give them this drug in culture, they would what's called apoptose or just blow up in the tissue culture dish. This is in stark contrast to what it was like when I first started in medicine, where they've identified cancer treatments by scraping fungus off rocks or grinding up tree bark or, growing algae in the ocean and extracting chemicals and just throwing it on cells to see what kills them. It was a totally empiric process. Now we know the structure of these molecules that are driving cancers or protecting them from the immune system, and we can design drugs, computer modeling and binding pockets and affinity to specific places and specific molecules, and end up with treatments for these cancers because of the application of science to medicine. And most often, the symptoms that people come to their doctor to get checked out are symptoms from metastases. So the cancer is spread to the bones and they end up having leg pain, or spread to the brain and they have a seizure or stroke-like symptoms. So that results in patients being diagnosed only when the cancer is already spread and surgery is not possible. So with something like CT screening, you can detect these small nodules that you never would have known were there in an earlier stage when they could be taken out.
Go-To for Lung Cancer is here for everybody at that point of diagnosis and beyond. We have many programs for anyone who's been diagnosed or those who have loved ones, but we also do research, advocacy. Yeah, we are trying to get the message out. Go-To for Lung Cancer is a huge supporter of low-dose CT screening. We want everyone to know that early detection for lung cancer does exist. If you meet those criteria, you should be going and getting an annual low-dose CT screen. And we want to really push that science forward to understand who needs to be getting it every year to make sure we catch as many lung cancers early as possible. Because if you catch lung cancer early, it's much more treatable.
There is a positive outcome possible with stage 4 lung cancer or with any cancers. I've heard stories where patients have been given the diagnosis of lung cancer. They go through 2 or 3 episodes of treatment and they don't see an immediate response and they give up. You have to have a positive attitude to get through the treatment, the testing and the treatment protocol that's necessary.
I think that you can never give up and have a positive attitude. I think once you think this is the end, it may become the end. And I never felt that way. I always thought that there is a future and something positive is going to come out of it. It did.